you are looking at Rome right now. That means it's ESC 2016, and we're talking about a state-of-the-art review coming in JACC. As head-to-head comparative trials between P2Y12 receptor antagonists are lacking, there is a selection of a specific agent for a specific patient that makes it very difficult to choose for the clinician. And so we're here to talk about a paper that's the long-term P2Y12 receptor antagonists in post-myocardial infarction patients, and we're facing a new trilemma. And so for that, I'm talking to the first author, who is Dimitrios Alexopoulos, an MD, professor of cardiology at the Athens University, University Hospital, and that's in Greece, obviously. I love your title, by the way. I appreciate the title of the paper. So let's start with the trilemma that you're referring to.
Well, actually, it's not so common word, trilemma. Dilemma is what we understand better.
Exactly.
But I think what we face nowadays is that we have to select a P2Y12 antagonist to prescribe to our patients between three of them. Clopidogrel, well-known, prasugrel, and ticagrelor. So we have three choices.
And they came from very different trials. I mean, you've got clopidogrel, 75 milligrams, that's mostly Charisma and some of the MI cohort of DAPT. You've got prasugrel, 15 or 5, and that's in about a third of the patients in DAPT, or ticagrelor, and that was studied in Pegasus TIMI 54. So these are some very different trials that may not necessarily compare well.
Exactly. There is no direct head-to-head comparison between the two agents. From the other hand, it has been well appreciated recently that the population with prior MI is a high-risk population. And the risk is not defined within the first year only, but it extends beyond the year. So it's common practice to give a P2Y12 antagonist for 1 year. But after that, what? And let's say that, okay, we believe in the long-term protection, and our patient has high ischemic risk, has low bleeding risk, so is ideal for a P2Y12 antagonist. Which one shall we select? Each one has its own advantages and disadvantages. Of course, clopidogrel is the most widely available. It's cheap. From the other hand, we know that almost 1 out of 3 patients, Caucasians, has resistance. So you get clopidogrel and you have no platelet inhibition. The other two agents, prasugrel and ticagrelor, are stronger. They produce efficient platelet inhibition, but of course we have to pay the cost of higher bleeding.
Right.
And so we tried in this review to combine all the available data in the literature from the 3 relevant randomized trials and also their sub-analysis to try to define which group of patients could get most of the benefit, and to define a group of patients with certain characteristics that would say to us that this agent fits better to this patient than the other.
So what can we learn from the data? What are you collecting here in this important paper?
Putting everything together, what you can say is that prasugrel definitely provides higher anti-ischemic protection than clopidogrel. That's for sure. Ticagrelor seems to be ideal for patients with renal dysfunction or with peripheral arterial disease. And the reason is that in these subgroups, in the Pegasus, the absolute reduction of ischemic events was very high. And also for patients who, at the end of the obligatory 1-year period, did not discontinue or after a brief interruption. If a patient is stable 1 or 2 years after the 1-year period, there's no reason to give him a strong agent. But early, it's a good period. So the ticagrelor fits to this population. Of course, clopidogrel has the advantage of being, as you said, available in all the parts of the world and also to be very cheap. So we can say this concerning the selection based on the effects on the anti-ischemic protection. Concerning bleeding potential, it's very difficult. And the reason is that the definition of bleeding in each of these big trials was different. It's just gastro, moderate, severe bleeding in Charisma and in DAPT, but TIMI, major in Pegasus. So there's no way really to get an idea or relative comparison.
Now, one of the things you look at in this review paper too, you note specifically special subgroups of patients. Who are the subgroups that you think you need to think twice about? You've mentioned a couple of them so far.
Exactly. It's patients with renal dysfunction, with peripheral arterial disease, and of course, patients with low bleeding potential. That's to start with. If a patient has moderate or high bleeding potential, then it's very risky to give extending treatment in this patient. We have another tool in our hands, is the DAPT score as well. So if you have a patient with high DAPT score greater than 2, then it's worth giving it. If it is less, then it's better leaving him.
Now, you also address things like cost. That can factor in, and practical considerations such as the applicability of variables such as the high prevalence of contraindications or warnings for prasugrel. So there are lots of things to think about, and that's why a paper like this is important, because you really do have to think about what you're talking about in this paper.
Exactly. Let's say that we have everything and we can choose between all the three agents. It is well appreciated that prasugrel has some limitations. We cannot give prasugrel in elderly patients or in those who are less than 60. This is from the studies on ACS patients. Ticagrelor does not have such contraindications. From the other hand, ticagrelor has the problem of adverse reactions, mainly dyspnea. So many patients who start on ticagrelor have to discontinue. And this has been described very well in Pegasus as well. It's high discontinuation rate because of dyspnea. Ticagrelor also is given twice daily. This may also affect a patient's compliance.
True.
So, of course, we do not have, as we said, direct comparisons between the two agents, but even if we had, then another important information is their applicability in real life, the cost effectiveness, the compliance of the patients. So there are many information that is still missing in this area.
Do you think we'll ever get the head-to-head trials?
Not really. And the reason is that personally I believe that the differences between the ages may be small, so it's very difficult to see them,
right,
to appear. That means that we will need tens of thousands of patients to compare, and I don't think that industry is interesting to...
Right.
Exactly. So we have to use the data that is available from the trials that we have up to now and do comparisons in our minds between subgroups and try to get out characteristics of patients that we believe that will have more benefit and less risk for them.
Well, this is why this particular review article in JACC is so important, because clinically it is really helpful to see the work of Dr. Alexopoulos and his colleagues. So in order to read this, please check the September 13th issue of JACC and for the state-of-the-art review. For Cardial Source World News, I'm Executive Editor Rick McGuire.